This is a Defocus Media production.
Audio Jungle.
What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus. What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover. Happy Thursday. Super excited because I get to hang out with my brother from another mother, and we're all about eye care shenanigans. Friends and family, it's a pleasure. It's an honor. It's truly a blessing to hang out with the mighty Dr. Jeffrey Fardink. How are you doing today, sir?
I am doing great. Recovering from Valentine's Day. I'm here with my real Valentine, Dr. Glover.
Oh, man, you just stole my heart, my friend. I really love it. I know everyone's out here like, man, this is a bromance going on, but hey.
That's right.
We got great energy, and it's that time of the year you got to show the love, right?
That's exactly right. I agree. Third time's the charm. Big number 3 here. I'm excited.
Man, I'm not going to lie. I didn't really do much this year for Valentine's Day. I was late to scheduling or setting up any dinner reservations or anything. So my wife and I, man, we just kind of took it easy. We just kind of chilled, relaxed, and in my household, I guess you could say Valentine's Day is every day. So we didn't.
I believe it. I believe it. But I had to make up for a lot of lost ground. I hired a Turkish metal singer to sing a song to my wife. So she liked that a lot.
Well, my wife doesn't want me to try to sing to her at all. If anything,
Right. Yeah, same here. I think my wife liked the metal singer more than me, so I got to be careful with Valentine's like that.
I love it, man. I love it, man. So, how's patient care been in February? I know January was real busy because everybody's benefits reset it, and now we're in February, and it's a shorter month, but people are gearing up for spring break and things like that next month, and I know there's a saying there's a recession or we're in it or it's about to come, but how's patient care been?
Recession looming potentially, but I haven't seen it so far. People, eye care is important. I guess people are definitely spending on it, at least around here. Getting their tax refunds too, another big thing this time of year to buy some glasses. So things have been busy, and I've been enjoying it.
I agree, man. In my practice, I've seen the same. We've been busy, just nonstop. I told someone literally earlier this week, it feels like week 52, the last year of the week, where everybody's trying to get in and use their benefits before the year is out. So I'm honestly, blessed and happy that, I'm a part of an organization that's able to put, people in a chair for me to help examine their eyes and help them live their best lives. So I'm super thankful for that.
Same here. Very grateful.
Super thankful to have this opportunity to chat with you today, my friend, as well. So let's get this party started, man. You ready?
Let's do it.
All right, man. For those that are new to eye care shenanigans, it's all about optometry news, but in a fun, easy way to digest the information with an expert out there known as Dr. Jeffrey Fardink. So today we're going to kind of jump into some topics. The first topic at hand is lowering IOPs with Doxy. I know this sounds crazy. There's something behind this. If you don't mind sharing with us, what kind of research, what kind of discoveries, what's the information out there in the world that we know a little bit more about, man?
So let's take a look at this. Dr. Dominic Opitz at the Illinois College of Optometry was treating a patient. The patient had stable glaucoma, and he was treating this patient for ocular surface disease with doxycycline. And he noticed over the course of treatment that the patient's IOP fell around 30%, which is significant, especially for a patient that's already stable and treated with topical drops for glaucoma. So I'm not sure how big this study was. He did a prospective pilot study where he enrolled some more patients. And the idea was find some patients who are stable with mild to moderate open angle glaucoma, taking topical drops for it, that also have ocular surface disease that's not potentially not treated. Begin treating it with 50 milligrams doxycycline every day, and then monitor IOPs at baseline 1 month, 3 month, and the 6 month mark. And the doxy was only for 90 days. So at the 6 month mark, they would have been off the doxy for 3 of those 6 months. And they found that the doxycycline appears to be lowering IOP in these patients. Baseline IOP was 16 millimeters of mercury. And then at 1 month, it'd fall to 14.67. At the 3 month mark, they're down to 13.5. And then at 6 months, that's 3 months later without any doxy, it only risen again to 15.3, still lower than the 16 baseline. So not really sure what's going on here. Potentially the anti-inflammatory properties of doxycycline are giving the trabecular meshwork, some more room for the aqueous to drain. But there seems to be something here.
Yeah, I love it. And, when I think about some of our super drugs in eye care, of course, Tobradex, I think everyone loves and adores
Absolutely.
for everything. Steroids, such as Lotamax, is another one of my favorite drugs that I use in my office. But I can't lie, over the last 2 or 3 years, doxycycline has really changed my practice, especially with my meibomian gland dysfunction, ocular rosacea, and to see this other piece to it with potentially lowering the pressure. That's huge, because when we think of glaucoma medications, we think about toxic issues with the front surface of the eye. So I'm really digging this, man. I think this is something that we need to dig a little deeper into and see how we can truly add this to the mix when it comes to treating glaucoma and dry eyes.
Yeah, I'm really excited about this. And Dr. Opitz is working on getting a larger study, enrolling up to 30 patients. I'm not sure again how many patients were in this study, but I guess fewer than 30. And I tried to do some background research to see if there's any other information about doxycycline and IOP, and there's really nothing right now that I'm aware of. So really novel approach, and I'm excited to see where it goes.
Well, I know all the glaucoma companies out there are already starting to do some research and try to figure out how to incorporate that into their portfolio, right?
That's right.
There's a lot of technology out there, a lot of bright people, a lot of money out there to do the research. So I'm pretty sure within the next year, we're going to be revisiting this.
Figure it out, yeah. And I agree with you, by the way. Doxycycline, great for my patients, especially with recurrent corneal erosions too. Very effective. It's really filled a lot of gaps, and it's been really helpful.
Yeah, that's a great call out as well. RCEs, man, that's a great option to have. Let's jump into the next topic, man. This is one that I'm very interested in learning a little bit more about.
So I care a lot about the cornea and corneal pain. We were talking last time about corneal pain and neurotrophic neuropathic keratitis. And despite my interest in this subject, I myself was mixing up the terms, and they are very different things. So this is not new news here. This is just a study I read, or a review by Dr. Tim Poyer. And basically just delving into neurotrophic and neuropathic keratitis. So neurotrophic keratitis is something that's pretty well understood, where there's damage to the ophthalmic branch of the trigeminal nerve, and the cornea begins to lose some integrity as a result. So this is a common way to look at this is stain without pain. So you look at the eye and it's not looking good. It's beat up, but the patient is not really complaining of any issues. And that's usually got a neurotrophic cause to it. And then,
can I ask a quick question? Can we put without pain on a t-shirt? I think that would do extremely well. What do you think?
I think we should do that. Even better. The next one, neuropathic. Guess what? It's pain without stain. So keep them both. Yeah. So neuropathic.
One or two.
Yeah, exactly right. Yeah. So I'm down for that. I get the stain without pain. No stain, no gain. So in neuropathic, this is when you have a patient where the eye looks fine, but they are really unhappy. They're really complaining of discomfort. And this is a newer thing that really the research is still out on. There's a lot of etiologies, a lot of things involved, potentially herpes keratitis, toxicity from preservatives, trigeminal neuralgia, fibromyalgia. It's a really complicated multifactorial thing that is typically going to be treated with drugs like gabapentin. And it's I'm grateful that gabapentin is now in the arsenal of a lot of optometrists. I can prescribe it here now in Virginia, and it's been great. In the handful of patients I have with neuropathic keratitis, they really get some relief from it.
Yeah. What is it that you cannot do in Virginia? Because it seems like you guys have really stepped your game up and have access to full scope optometry. I mean, you've expanded scope. I mean, you guys are rocking and rolling out there in Virginia, my man.
Yeah, what can we not do? I don't know. Take a break, I guess. There's a laser law going through. We're going to have YAG caps out here for optometrists. It's great. Come down to Virginia. Great practice.
Hey, man, I'm right beneath you in North Carolina.
That's right. North Carolina's great too.
Love, and that stuff can kind of just drip down to us, so we get the same scope expansion as well, my friend. But congratulations on all the great work, and thank you for also just really practicing full scope optometry. You know, if we're not out here practicing it, man, we're not going to be able to show that we have the knowledge and the skill set to help these patients by practicing full scope optometry. And it's all about expanding scope, protecting our rights. So I know we say this on every episode, but show love to the AOA. Get out there and make it happen and support the cause. That way we can continue to build this amazing profession known as optometry. So again, congratulations on all the great work out there, man.
I'm happy to be here, and I completely agree. Full scope's so important. I definitely don't want anyone to do anything they're not comfortable with, but I encourage you to work on expanding your comfort zone. Build relationships with MDs in the area, maybe who can help guide you into different treatments you're not familiar with. Learning doesn't stop at the end of optometry school, and it's been great to really expand and do more things that I thought I wouldn't be comfortable with, and able to do to help my patients. So.
And you hit on something that's huge. You don't have to do everything.
Right.
You're not be great at everything. So feel free to refer to another optometrist, especially when you start to expand your scope. If it's not your cup of tea, there's someone down the street that may be able to take that off.
Absolutely.
Just make sure that you truly practice full scope, but to the utmost of what you feel comfortable with. So great call out there, my friend.
And great call out on your part. We need to be better at referring to other ODs as a whole, the profession, and myself included. So I'm excited about the scope expansion, give more opportunities for that. Amen
to that. Now, I wanted to circle back on something from last week or last month that you touched on, and that was smile, right?
Yes.
Back last time, I know you wanted to come back in and talk about some topics from that discussion last time we were on.
Well, I'm not sure if I want to touch base on it because I've got to admit that you were right and I was completely wrong about something I said in the show. We touched base about the very sad story about the meteorologist Jessica Starr who took her life, and potentially the refractive surgery may have played a role in that. Of course, mental health is a very complicated thing that's very important to me, and it's hard to make a judgment like that. But she had SMILE procedure. She did not have LASIK like I indicated. And you're exactly right, Dr. Glover. I've heard less and less about SMILE over the last few years. And I tried to do some work here and see why that is. And, there's not anything that's new about it, really. Not like it's off the market or something. Right. It's just as we've seen more patients and have more outcomes, I think it's kind of fallen out of favor just over the newer generation LASIK technologies. I found a great post here by a refractive surgeon in California, Dr. Avneet Gar. And SMILE eye surgery may leave you little to smile about, which love that. Got to embrace the puns. So some of the drawbacks of SMILE, she, in her opinion, and based off of the research that she's pulling from here, there were claims that SMILE was less invasive, smaller incisions. It's really not true because SMILE does have a smaller incision, but there's multiple incisions in the procedure. So overall, the incisions that are being made are overall longer. Right. So yes. And the recovery time in SMILE is not as quick as was thought. Patients are taking up to a month to recover in certain cases. The refractive outcomes aren't quite as good as the modern LASIK procedures. Dry eye. There was the thought that SMILE will disrupt fewer corneal nerves. This where they're removing this little lenticule from the corneal tissue with SMILE. And that is true. Fewer corneal nerves are disturbed. But however, patients seem to have just as many dry eye complaints, if not more, than LASIK. And also there's an issue with corneal weakening and potentially causing ectasias that is more prevalent than LASIK. So it just doesn't really seem like it's taking off in popularity, especially compared to the new advances in LASIK.
Yeah. Let's talk about LASIK a little bit. Are you seeing an uptick in folks that want LASIK, especially after the pandemic, or are you not seeing as many people coming in and asking for it? I know historically in my practice, it would just come in waves,
Yeah.
Going to come in, and the next thing you know, the next 2 weeks, I'm getting bombarded by potential refractive surgery referrals, right?
Oh, yeah.
Your practice in Virginia.
I think everything that I experience is just like that. It seems to come in waves for whatever reason. Definitely during the pandemic with the mask wearing, people were looking for ways to get out of glasses, a lot of contact lens fit opportunities and a lot of refractive surgery opportunities. I think maybe it slowed down a little bit because people aren't wearing masks as much, but it still seems to be a very popular option. I wouldn't say it's going out of style or anything like that.
Gotcha. Good to hear. So let's take it to the next one, my friend. The gift of sight to children. We all love kids. So this is a topic that is going to really, touch your heart. And we got to give a shout out to, the folks that are really putting some energy and some money behind this topic. But take it from the top if you don't mind.
Oh, of course, my pleasure. This is a great one here too. So cataract surgery, about as routine a surgery as there is, something that is very well understood. But pediatric cataract surgery, these patients that are born with cataracts, it surprises me reading this article here about how we don't really know as much about pediatric outcomes as I would have thought we did.
Yeah.
So
it blew my mind as well, man. I
yeah.
couldn't believe some of the things that I was reading. I'm like, we're so advanced with all these different surgeries, but when it comes to kids and being able to help their vision at an early age, like we're not putting any thought or power behind it or brain power behind it. So this article really touched me, man.
Right, me too. And it seems like something that's fixable. So the issue, of course, is that when a patient is born with cataracts, they need to be removed immediately to prevent deprivation, amblyopia, among other problems. And what do you do at that point? The patient's probably plus 10, plus 12, really high hyperope. And very rarely is an IOL, intraocular lens, installed in the patient when they're infants because their eye is going to grow a lot. And it's hard to really, pinpoint what refractive power they're going to need. It's hard to determine if they're going to have a big, myopic shift, axial length increase, things like that. So
that scared me, man, is because of that. I mean, we all use these devices, right? Cell phones, tablets, read books, those things like that. So, how can you truly predict that if we're worried about the eyes elongating? I mean, there's maybe there's going to be some type of IOL implant where it has kind of like the myopia control glasses, where inside of it has the little what do you call those things?
Like the little dims, the little
and we talked about
the little lenticules there.
Right. Maybe that's the solution.
Man, that would be awesome. I would love that. Yeah,
we want our check for coming up with that idea.
Right. Yeah, you have to change it out when you're 25. That's all right. Whatever, not a big deal.
But no, this is great, man. Continue touching on it, man. I mean, because
so
lives of many.
So the IRIS database is something that was established in 2014 to help with MIPS reporting. It's a big database of surgical procedures and outcomes that ophthalmologists can enter into, and they're incentivized to enter their patient information into this database because it's how they report for MIPS, the merit-based incentive program in Medicare. So this is a huge database with millions of patients and surgical outcomes in it. And so the FDA and the American Academy of Ophthalmology are partnering. FDA got a $400,000 grant for this, and they're going to really dive deep into the IRIS database to examine pediatric outcomes from cataract surgery between 2014 and 2020, and really see what works, what doesn't work with this huge data set, because it's not a known question. We're not really sure what the best treatment options are. So having this huge data set to analyze is really hopefully going to get us some good answers.
Yeah, and 400,000 it's not too shabby as well.
It doesn't hurt. It doesn't hurt at all. Yeah.
So super excited to see where that goes. We're probably gonna have to circle back to this topic sometime next year just to see if there's any advancement as well.
Definitely, and they say that they expect to have good results by the end of this year, which surprised me. So hopefully we'll have some new things to report on this pretty soon. There's another thing here too. Another part of the grant is that they're going to be using artificial intelligence algorithms to determine, diagnose diabetic retinopathy, basically work on that with this huge data set. And I think that's also a great thing that's going to come. You get to use technology to help our patients that way.
Hey, AI, VR, the metaverse, all that stuff is the future. And that's kind of a good segue into our next topic of conversation, VR vision experience. Talk to me about that.
Yes, sir. Johnson & Johnson is launching this virtual reality experience for clinicians. It's a training module to help clinicians really get some hands-on experience with the Johnson & Johnson contact lenses and products without necessarily having to fly to a conference or a training seminar. It's not available in the United States yet, but the technology is pretty far along, and I think just working on getting approved at the moment. I spoke to someone in Johnson & Johnson about it, and they're really excited about this. So it's a way for clinicians to put on their virtual reality headsets and get to play with some really exciting J&J technology. I can't wait to try it myself.
Hey man, I'm super excited about this technology because as eye care professionals, this is what we need to be able to show a patient what it looks like in various ranges with contacts that are multi contacts, or even imagine progressives.
Yeah.
Being able to show the different levels of what progressives look like. You can have a premium option where there's less distortion, more of your entry level where there's more distortion, and be able to toggle between those two different zones so patients can see, but then also add into the mix of what your old prescription looks like versus your new
Yeah.
prescription. I mean,
That,
technology, man, I'm telling you, it is going to change the eye care industry, and it's going to make us just be at the forefront of healthcare in general, because there's so many things that we can show our patients to enhance their lives. And I mean, even think about the piece of if you have diabetic retinopathy or macular degeneration and being able to show that with VR,
yeah.
this can really help enforce compliance with our patients when it comes to wearing your sunglasses, having the right diet. I mean, I'm really looking forward to this technology to complement all the things that we do. This is going to take patient care to the next level.
I could not agree more. I'm very excited about it. I can talk and talk and educate patients, educate, medicate, operate. But really, if you can show the patient what you're talking about, it just goes so much deeper. So we're talking about trial frames being so great. That's a
Yeah.
great point about progressives. I've had so many patients say, "Can you show me what a progressive's like?" And I'm like, "No."
Yeah.
So that's true. VR would be a great way to do that.
Yeah. And then just think about the piece with kids, right? As far as myopia control, being able to have them put on that headset and see what elongation looks like of the eye, and then simulate
Yeah.
retinal detachment, and maybe having, a little story followed by that showing how it impacts, a kid's life or an adult's life, and, just the overall impact in general. I mean, there's so many different pieces that we can go into, and just the education that we'll have with this virtual reality is just
And
unmatched.
I can't wait. And speaking about kids, that reminds me of something else that's very important. I'll often have maybe dad come in with his son, and the kid lost his glasses six
Yeah.
months ago, and the kid hasn't been wearing anything. And the kid could be a -3, and the dad's like, "Oh, he broke his glasses again, lost them again." And I get it. It's frustrating. It's expensive. I'm a parent. I totally understand. But I just don't think a lot of the time the parents just don't realize what they're subjecting their kid to, and the kid doesn't have his glasses. So I have a big proponent of letting the parents see what the kid sees like. So if that kid's a -3, I'll put +3 in a trial frame, put it on dad, and then dad gets to see what his kid's been walking around with for the last 6 months. And boy, then he understands how important the glasses are. So I think that's something to think about.
And look, you got me going on this for days, and I promise I'm gonna get off of this. But I get innovation and technology. But think about this. Think about the access to just some of these simulations, whether it's jumping into the metaverse and doing this before you even walk into the exam lane, before you even walk into the office, having the education about what different lens technology can do for you, having the education about various conditions and experiencing it firsthand. That pre-education can really change the game for us, but also streamline the patient journey, right?
Mhm.
Patients
Yeah.
don't like to live in our office. They like to come in, get what they need, and move on. That will really change the game as well in regards to just that pre-education before they walk into our office. So again,
Completely
super
agree.
excited about the technology. Can't wait for it to come. Our next topic up is something that I'm interested in learning a little bit more about, because I was a little lost in the sauce when I was reading the articles,
No worries.
breaking it
I,
down. But this topic is lipid cycling pathways.
yes, I was. It was confusing. It was a very confusing little article here, but the topic it covers was so interesting that let me take the time to try to explain it better. So basically, there's a patient in her 80s who's being followed for her age-related macular degeneration. She also has in one of her eyes a very large, full-thickness macular hole. It's probably half a disc diameter in size, very large, full thickness. There's no photoreceptors at all in
Okay.
that area. And over the course of 7 years that she was followed with fundus photography and OCTs, soft drusen develop in the macular hole, which is very interesting because the conventional wisdom is that drusen typically are developing from Brooks membrane debris. The Brooks membrane debris is accumulating as the photoreceptor outer segment membranes are being phagocytosed and building up this waste product in that area. But there's no photoreceptors here because there's a macular hole. So how is the drusen accumulating? And the story here also mentions how they're doing some assays of human tissue post-mortem and finding that there's really convincing evidence that drusen and other deposits in the retina like that probably have a diet-based component to them from what things that we're eating. So there is still, of course, drusen that are forming as a result of phagocytosed outer photoreceptor segments, but apparently drusen can also form from potentially dietary fatty acids. It's really interesting.
Wow, that's huge, man. And that's why it's important to have the conversation with your patients about what you put in your body impacts your eyes, right?
Yes,
Very
absolutely.
Conversation day in and day out. And I have had an uptick of patients coming in asking about what should I incorporate into my diet, how should I protect my eyes. So that's good to see and hear. But sometimes we do need to take it to the next level and have these conversations and keep awareness amongst the eye care community as well, because this was not on my radar. You shared this article and I was reading it, and it was a little difficult to follow, but the way you broke it down, man, was magical. So I really appreciate you, my friend.
Hey, my pleasure. My pleasure. I wish I could share the pictures from it. I was working on getting a license for us to share it, and it didn't happen. But it's really neat. It's published in Eye.
Gotcha. Well, hey, man, this has been fantastic. It's always a pleasure to hang out with you and, report the optometry news. For all those that are out there that have an interesting news article and you love for Dr. Jeffrey Fardink to review it and break it down and analyze it and make it more digestible, just hit him up. You can follow him on Instagram at DK Units.
That's right.
Name, by the way. So if you're watching, listening, go support him. Again, that's Fat DK Units, FATTDK UNITS. You can tell this guy truly loves contact lens. So make sure you go support him. But reach out and let us know if you see anything interesting and cool that we can report. As always, my friend, it's always exciting to hang out with you. Let's continue to do this. I'll see you this time next month. And
Can't wait.
My man. For all those out there, thank you again for following us. Stay healthy, stay positive, and stay blessed. And until next time, peace. All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the D-Focus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars. And make sure you follow us on all social media platforms. Facebook, Instagram, Twitter, LinkedIn, you named it. And our handle is at D-Focus Media on all platforms. And until next time, be sure to keep it 2020. And we look forward to seeing you on the next episode.